Well, it's great to see you here, and you're addressing a very important topic because you're looking at late recurrence, because although a lot of recurrences, if they're going to happen within the first 5 years, they're happening at 10 years, beyond 5 years, 10 years, even 15 years. What can you do about that as a doctor, and what are you addressing right here at the meeting in Brussels?
You're absolutely right. Late metastasis is particularly for hormone receptor positive breast cancer, one of the most burning clinical research questions. Because in fact, and this is especially true for the overall good prognosis hormone receptor positive breast cancers, we lose more patients after 5 years than we lose in the first 5. There are several studies out there which have shown that extending the duration of treatment can help in reducing these late metastases.
And there's a lot of talk about having longer courses of hormonal therapy, isn't there?
Most recently, the Atlas trial has demonstrated that 10 years of tamoxifen may be beneficial for some patients as compared to 5 years. And there is a number of other trials of how we call it extended adjuvant therapy, mainly aromatase inhibitors after 5 years of endocrine treatment. The issue with this is that in order to obtain benefit, we have to treat tens of thousands of patients, and most of them won't derive any benefit because they are actually at very low risk. So this is what sparked our interest in researching modern diagnostic tools in order to be able to more accurately predict the risk for late metastasis.
Of course, we're here at a conference where molecular markers, genes, DNA, RNA, gene expression is the order of the day. What do you have to offer us in this respect?
What we did was that we have done a study on a large clinical trial, ABCSG8, using a multi-genetic test called PAM50, basically investigating 50 relevant genes, and we validated that test in our large clinical data set.
You used PAM50, but of course there are quite a number of different possible gene tests that you could have chosen. Could you explain to me why you went for PAM50, although it is called the PAM50 ROR, risk of recurrence, isn't it?
The readout of this is basically the risk of recurrence, and this again is grouped in a low, an intermediate, and a high risk group of patients, as determined by the overall risk for metastases at 5 years, 10 years, 15 years. There are other tests out there. We chose PAM50 because it's RNA based and it can be done in a decentralized way, so you don't have to send all the material to one single place in the world. But it can basically be done in any qualified pathology laboratory around the globe, which I think in the long run will help to make this technology available to patients.
So what did you find?
What we found is that, and we've particularly focused on late metastases, metastatic events after year 5, is that the PAM50 ROR defined risk groups pretty well differentiate between patients at extremely low risk for late metastases, those with a somewhat intermediate risk, and a high risk of metastases. So what is new about this is that all the risk assessment tools usually describe the first 5 years, maybe the first 7 years. We basically excluded the first 5 years, because what we do against that risk is we apply adjuvant chemotherapy, and we focused on the follow-up period after 5 years. Up to 15 years, we have reliable data for, let's say, 11, 12 years, because this addresses the most important question of late metastases.
Now, just how good is this test, though? Because you might well be tempted to prescribe hormonal therapy just in case.
Well, the issue is that prescribing something just in case is what we do, and it leads, what we currently do, and it usually leads to what I call the overtreatment disaster. So if we can safely identify a subgroup of patients at particularly low risk, you know, we would be very relieved, patients and physicians, in not having to prescribe this patient. And this is exactly what we demonstrate using the PAM50. To give you some numbers, for the low-risk group of patients, low risk for late metastases, the overall rate of patients experiencing metastases between year 6 and 10 is 1.3%. So that's really tiny, less than 0.3% per year. And most physicians around the world would agree that with such a tiny remaining risk, there is no justification to recommend to these patients the extension of endocrine therapy with all its related side effects.
Okay, that's still quite a small number of patients who are being spared the therapy, although a significant number globally, of course.
No, that's not a small number because it's 40% of all breast cancer patients. It's just that these patients have an excellent prognosis, but within that excellent prognosis subgroup, using these tests, we have been able to identify a subgroup of excellent prognosis patients with particularly excellent prognosis and with very limited risk of late metastases. So we're not suggesting that these patients should not have any treatment. We're just saying we know that the standard duration of treatment is pretty much as good as it gets for these patients.
Right, now it's one thing sparing treatment, but what about the other patients? Is there any evidence that your risk scoring can help you to treat better the patients who really do need therapy?
Definitely. On the other hand, you know, in high-risk patients, all these data come from a trial that did not use adjuvant chemotherapy. So these patients had endocrine treatment only. But if I now see that after 10 years or 15 years, in the high-risk group of patients, we can identify individuals with a 20, 25, even 30% risk of metastases, I would at least in hindsight say, well, we should have treated these patients with additional chemotherapy, for example. This is more difficult to prove because clearly now you would have to do a prospective trial to demonstrate that this is something that can be reliably done. But still, I think individualizing treatment is based on individualizing risk assessment. And if we can differentiate late risk between 0.3% and almost 10% in the high-risk group, that's going to make an impact on the clinical decision-making process.
What about intervening at that earlier stage where you're deciding between hormonal and chemotherapy?
Well, this is about the addition of chemotherapy. I had demonstrated those data at the San Antonio meeting in last year, so we are not focusing on this this time, but it's already established now in 2 large clinical trials that using the PAM50 score, you can identify a so-called higher risk group of patients who should receive adjuvant chemotherapy in addition and on top of their endocrine intervention.
Okay, and you've been doing this on large numbers of patients, you're confident of your data. What do you advise practicing doctors to do right now?
Well, there is always a gap between research and clinical routine. The PAM50 test has now a CE mark in Europe. I understand that in the United States, the FDA is scrutinizing the data and defining whether this will be approved in a way for a diagnostic tool. But I think that for me as a practicing physician, if I have that individualized information about late risk available at the time when the patient and myself discuss the extension of the duration of adjuvant therapy, this is going to be very helpful. It's going to indicate whom to suggest that a prolonged treatment would be most likely beneficial, and maybe even more important, who could be spared the side effects of unnecessary treatment.
And bearing in mind the fact that you have to get your head around the fact that many patients are already at low risk, could you interpret these findings in terms of how many cases of unnecessary treatment could you save globally, and how much morbidity might you prevent by this?
Well, it's a little bit difficult to give you an accurate answer to this because this hugely depends on, you know, the healthcare environment we live in. Obviously, in an African country, this may not be the most important issue. One can calculate that in, let's say, in the US and in Europe, this would be a little over 100,000 breast cancer patients who could safely be spared unnecessary treatment if we, with additional data, validate these results and get them to be available for the general public.
So what would you like doctors to take home from all of this?
I think the take-home message is that risk assessment is a very important part of clinical decision making. Just prescribing to be on the safe side does not cover all the dimensions of treatment, because some of these treatments with the side effects exceed the potential benefit, and this heavily correlates with the general background risk of relapse. We are approaching an era where we really have modern diagnostic tools with these multigenetic assays to be better able to fine-tune and individualize treatment for our patients, and I think that's very encouraging.
Michael, thank you for joining us on eCancer TV.
My pleasure.